This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago 2014. I'm Tom Luescher, Editor-in-Chief of the European Heart Journal, and I'm talking to the primary investigator of the MMR trial of the Cardiovascular Surgery Network. And I have the pleasure to talk to Robert Mitchler from the Albert Einstein College in New York. And we have a discussant, Louis Perot from the Montreal Heart Institute. Welcome, gentlemen.
Thank you.
So let's start with the hypothesis behind your trial. What made you design this trial?
Well, this was really, in terms of addressing, an attempt to address what is a frequent issue in cardiac surgery. Patients referred for bypass surgery who have moderate ischemic mitral regurgitation. The question is, do we repair that valve or should we leave that valve alone?
So how did you determine the moderate MR? Was this by echocardiography mainly, or?
Yes, this was by transthoracic echo. All the echoes were read in a core echo laboratory to confirm. And one of the unique features of this trial is that it is a very well-defined population with moderate mitral regurgitation. We used an integrative method to determine moderate mitral regurgitation, which included the American Society of Echocardiography recommendations, and examined three fundamental features, that is effective regurgitant orifice area, vena contracta width, and the left atrial jet, the regurgitant jet area to left atrial area. So we have a very well-defined population of patients with moderate mitral ischemic regurgitation.
And what were what was the age of the patients, the comorbidities?
So this was a sick population of patients. The baseline characteristics between the two groups, one group of 151 patients received bypass alone, and the other group of 150 patients received bypass surgery with a undersized annuloplasty ring. So the baseline characteristics were similar. Mean age was 65, 30% were women, 20% were non-whites. The only difference was more atrial fibrillation in the CABG alone group. 35 patients with atrial fibrillation as opposed to 19. But both groups had, as a concomitant procedure, the same number of Mays procedures, 7%.
Very good. And so you randomized the patients, and this was blinded only for the patient, not obviously for the operator, was it? Or?
Well, no, we couldn't blind the surgeons, but the echocardiographers and everyone else in the treatment of the patient with respect to the endpoints of the study were blinded. Now, we used as a primary endpoint reverse remodeling as determined by left ventricular end systolic volume index.
Again by echo?
Again by echo. And this was done within 30 days of the operation, and we were not influenced by the intraoperative transesophageal echo as to whether or not to proceed with the surgery. There were a few crossovers, but that did not impact on the intention to treat analysis when we looked at the as treated analysis.
Yeah, but the primary analysis was an intention to treat,
exactly.
Was it?
Yes.
And what did you find?
Well, first of all, we looked at all 301 patients. We did have deaths, but we used a Wilcoxon-Rank sum test to look at these patients. So deaths were attributed with the worst ranking in that analysis. And what we found was that, first of all, that the addition of mitral valve repair did not result in a higher degree of reverse remodeling at 1 year over bypass alone. The second thing we learned was that there was a higher prevalence of moderate and severe mitral regurgitation at 1 year in the CABG alone group, 31%. But it also meant that roughly 70% of the patients had no trace or mild MR at 1 year with CABG alone. So very impressive CABG alone result. And now with the mitral repair, the moderate or severe prevalence at 1 year was 11%. So
so it was lower than in the CABG.
one third lower in those patients who had CABG with a repair. Now there was a safety signal because the patients who had repair also had more neurologic serious adverse events, statistically significant, and those adverse events included stroke, TIA, metabolic encephalopathy, and seizures. And in addition, as one would expect, the patients had a longer operation, both cross-clamp and bypass times, and they also had a longer ICU and hospital length of stay. Now, these patients were sick. 50% of these patients had diabetes, 50% had heart failure. 20% of the patients had renal insufficiency, 10% of the patients had a prior stroke, and the mean LVEF, the ejection fraction in both groups, was the same at 40%, so moderately reduced ejection fractions.
I see. Yes. So how do you explain the safety signal? Is this just because of the prolonged operation time, or?
Well, I would think it's more related to opening the atrium. And there are adverse consequences whenever the heart is opened, the introduction of air, potential debris, and clot forms along suture lines. All of these things can lead to these additional neurologic events.
So, as a discussant, what would you say related to this trial?
A few things to realize is that, first of all, this trial is quite an achievement as surgical trials go, or cardiovascular surgical trials go, because the prior randomized trial in this subject that came from the UK just randomized about 70 patients. And so this is 300 patients, and to have multiple centers get together and get to do this trial on surgical technique is an achievement in itself. I think prior to this trial, I would say most centers that did a lot of mitral valve surgery were very aggressive and would ring most of these patients in the past. And on the contrary, those with less experience with mitral valve would just do the cabbages and hope for the best. So I think that this study with the follow-up at 1 year gives us first a perspective that you don't necessarily need to ring everybody. There's no functional benefit at short term. And it will help us, obviously, with longer follow-up, determine which patients exactly we should ring, and ultimately whether or not we can forego this extra procedure, because there is, as was shown, a little bit of increased morbidity if you do an extra procedure.
And also, what's interesting is that those with bypass alone did actually improve in terms of their MR, if I understood correctly what you said. And so is this because you get better perfusion and the papillary muscle would work better? How would you explain that?
If I may, I think it's because these patients had reversible ischemia. And they were, after all, being referred for bypass surgery. So that in and of itself would lead to the anticipation that we would reduce the size of the heart. I think one of the other very interesting features for me is the recognition that at 1 year, the majority of patients in both groups were moderate in the severity of their mitral regurgitation. They were not, there was not a large population that progressed to severe. In the CABG alone group, it was only 5% that progressed to severe.
So in most you could stabilize or even improve it.
Exactly right. And in the repair group, it was less than 1% that progressed to...
So a little bit better, but not as much as you would anticipate.
Well, I think with repair, we would anticipate...
Yeah, but the difference was not as big.
The difference was not as big,
as you would anticipate, yes.
Yeah.
So this is actually good news, I think, for the patients. They get simpler operations and have a good chance to be repaired without the repair. Do you think in the future it might be useful to have an imaging technology like a PET to see whether the circumflex or the big right that supplies the mitral papillary muscles are ischemic or not?
Well, I personally think that that is an important question to be asked, and whether we could do that trial in the future using that as an entry criteria would be excellent. This trial will provide us with a wealth of information, and along those lines we do have regional wall motion and global wall motion, and we also know which territories received a graft and which did not.
So you can do this sub-analysis?
I think we will do this sub-analysis and address exactly your question, but it will be post hoc, and the trial you mentioned would be very, very ideal to look at if possible. But I think that leads to difficulties with enrollment.
Yeah, that's not trivial, yes. But
well, you see, in this population, about I believe 60-65% of the patients had prior infarct. So the subset analysis of these patients might answer partially, assuming these were not reversible ischemic patients. Right. So we'll be able to take a look at that. And obviously we had considered it many times in the design of the study to include viability, but obviously that would have increased the cost and complexity, and we had to let go of it. So.
Well, thank you very much for sharing this clinically very important trial with us.
Thank you very much.
Thank you.